of this disease. So that's why you get these disruption of the basement membrane and these big blisters and huge amounts of exudate. You can actually, I do not know if it is a lab you can routinely get. You can use this as a diagnostic. If someone's presenting, you're not sure that, or you want to confirm a diagnosis of bullous pemphigoid, you could order it. You can also get one for the BP230 antibodies as well. You could also use it as a way to find out if your patient is responding to therapy, because it takes a while to get rid of all these blisters. It's a very distressing disease. I've seen it a few times in the elderly, mostly people that came in through the emergency room. They really are distressing. So very large vesicular lesions can appear anywhere on the body, can cover the body, or be localized. This is a very common presentation of those. Let's see. So since it's an autoimmune disease, they're going to use a lot of immune therapy to modify the disease. The biggest thing, and you may have gone over this in Clin Med, is they teach the caregivers to pop those vesicles as they come up. They teach them to disinfect them with alcohol and then pierce them at the side, let it collapse, and let that skin roof or flap serve as a covering for the skin that's underneath. And so they do that daily, on a daily basis. So teaching patients or the caregivers how to recognize infection. So you can imagine superinfection would be a major problem because they're on immunosuppressants and you are constantly exposing that underlayer of skin to the potential for skin bacteria. So the major goals of therapy, if you go down about a third of the page, is to decrease blister formation. So first we want to arrest the process. We want to stop new lesions from coming up. Then we want all the lesions that are there, once we can arrest the disease, is to get it to go to where we are not getting any new ones. Or, I'm sorry, that we are healing the skin that's there, and then the last phase, the maintenance phase, is you're wanting to no new ones. So we want to put them into somewhat of a remission status. So it's a chronic disease, chronic maintenance therapy is required for the rest of their life. So decreasing blister formation and itching that is associated with it, promote healing of the blisters and the erosions, and improve their quality of life. You can imagine how distressing these could be, just in looks, pain, other symptomatology. So we talked about the blister care, infection, the 3 phases. So the cortisone therapy is going to be the topical steroids, and we're going to use the high potency or super potency topical steroids like clobetasol to treat them. And this is one of the cases where, at least for extensive disease, like you would see in most of these pictures, your topical is more effective than your systemic. For moderate, they're about a wash, either one. So you can use, you would go with topical first, unless you have really localized, which would be good for localized. You might, for people that are very widespread, have to go with systemic just because of the amount you're having to cover. If you look there at the very top in terms of efficacy, I found this interesting, is that in extensive patients with extensive bullous pemphigoid who were older, 1-year survival rates, disease response, and severe complications were significantly higher for patients with those treated with oh, that's true. Okay, I've read it in the reverse. Were the topical over the systemic. Sorry, I faked my own self out. So when you go through there, BP is not blood pressure, it's bullous pemphigoid. When I picked it up from last year, I'm like, why did I put BP over there? But it's the disease. I did that last year and I forgot. Okay, so we're going to use the super high potency clobetasol, and we're going to use it until the disease arrests. So we're going to look at inflammation, blister formation, itching, and then we're going to move about 2 weeks beyond that. We want to get rid of at least 80%. These are just kind of markers of cessation of the disease process. Then we'll taper. The tapers are long. So these are similar concepts to most of the chronic immune dermatoses that we have talked about. Arresting the disease with immunomodulators or immunosuppressants, and then a slow taper until you can find a dose that will maintain them, or they go into remission for as long as they'll stay there. So that's not new concept. You're going to apply that to this disease as well. The other is that the adverse effects of the topical steroids is the same here. So what are they commonly? The three big ones. The skin atrophy, okay, probably not going to go away in this case. What else? The telangiectasias, the stria. So all of those are possible. They also put folliculitis can also occur. Adrenal suppression also because the amount of body surface area that's being covered. Systemic we usually don't use. If we do, it would be prednisone, the one you're familiar with the most. Same approach to disease cessation, tapering, all of that's the same for the systemic as it is for the topical. Adverse effects, if you look down there, this is the same adverse effects that we've talked about with systemic steroids. This ought to be something emblazed in your brain, going over and over and over again, because you see that we use steroids in multiple and many different types of diseases, organs. So knowing those side effects, not only for the topical, but also the systemic is important. Okay. So look through those again. So metabolic or high blood pressure goes up, blood sugar goes up. We also can cause damage in other organs like the eyes with cataracts, muscle wasting, skin thinning, bones more breakable, easy bruising, all of those. Increased risk of infection, weight goes up because we also get fluid retention, increased appetite, axis suppression, psychological problems. Those you should be able to rattle off. We have seen them over and over and over again. Go back over them, kind of get them more solidified in your brain because it's a common drug that we use. Okay, questions about those? Very similar. It's mostly here it's just what guides what are your endpoints, or what's the telltale signs of, or clinical signs of response. Okay, so glucose-sparing agents, this is the same thing we've talked about when we talked about rheumatoid arthritis and SLE and some of the other different diseases that use a lot of steroids. So these agents, usually they're immunosuppressants, they work by a different manner, and they allow us to work on the immune system in a different way, and they usually allow us to decrease the amount of steroids we're using, so decrease. So the end game there is we're trying to reduce the amount of side effects that they could have long term and maintain whatever disease suppression we have already attained. Here, the goal is to get them off the steroid or get them to a very low amount and switch them over or maintain them with the glucose-sparing agent, or glucose. Sorry, we do the same thing with insulin. Sorry. We're going to overlap those agents, and then start the taper with the steroid. So that's an important to look at. Starting the steroid, before we do a taper, we're going to start them on an immunosuppressants, we're going to overlap that, and then we're going to start the taper. Okay. Makes sense? We haven't talked about doing that quite like that before. Okay. If you can get them off the steroid, great. And that would be the goal of the taper and the use of that immunosuppressant. So the immunosuppressants are ones that you have seen before. We talked about these with RA and with SLE as well. So azathioprine, very old immunosuppressant. Mycophenolate is CellCept, a newer one. Methotrexate, you remember, you can use it in a lot of different autoimmune diseases. The things you worry about that we've talked about with other autoimmune diseases are going to be, we would worry about them here as well. So what are the big problems with using immunosuppressants? What? Increased risk of infection, and not just a common cold. What kinds of infections are we more worried about? Say it again. Okay, life-threatening ones would be common. What is the other big side effect? Hepatotoxicity is frequent. What's the other thing we're worried about inducing or allowing to happen when we use an immunosuppressant? Cancer. Okay, so cancer and infections are the major side effects of those drugs, or complications, or probably a better way to say it. So all the things that we did at baseline with the other diseases, we're going to do here again. So when we use, especially like methotrexate, what do we have to get before we use it? Pardon?
Baseline labs.
What? Okay, so what are those baseline labs? CBC, because they are very myelosuppressive. Methotrexate, all lines. Okay. Remember, platelets is one of the things you look at when they get below 50,000 UDC. Kind of bringing those things back from RA. What else? TB, hepatitis B, hepatitis C. So those are three latent diseases that can be uncovered or unleashed by those drugs. So you could do your test to make sure that those are not already present. Okay? So people can have those diseases for a long time smoldering, and then these can reactivate them. Okay, what else? Pregnancy tests for females. These are, since we're dealing with older, you may not think so much about those, but we would do it in younger people. It's a good reminder. What else? HIV. HIV in high-risk patients, you certainly would. And what are your two organs that are going to get rid of and metabolize most of your drugs?
Liver.
Kidneys, liver. Okay. So again, every time, make your brain go through that, and you'll start remembering. Okay, good. Let's see. Methotrexate, good reminder, it's a once weekly. Why do we only do it once a week? Possibly, but another reason.
Is it the pulsing?
Pulse, did you say pulse?
But then one of the medications had like a pulsing effect that you only wanted to give it so long.
Yeah, the hepatotoxicity goes way up. So one of the things, remember about methotrexate, we talked about if a patient has caused lots of GI upset. So if we have to divide the dose, remember we talked about you have to get both of those doses in a 24-hour period. Remember that little quirk? Okay, so that's because the liver toxicity goes up a lot. What other drug do we have to give with methotrexate when we use it?
Folic acid.
Folic acid, same thing here. All right, good. So those are immunosuppressants, so anti-inflammatory agents. So here, it's kind of strange, but some of the antibiotics have good anti-inflammatory. One thing to kind of help you remember that is that we use a lot of tetracyclines for acne. She probably talked about that today. Okay? Mostly, a lot of what we get out of that is anti-inflammatory effect. It's an odd. Low dose of tetracyclines are anti-inflammatory. Dapsone, another antibiotic, we don't use it very often, also has those anti-inflammatory actions. Dapsone is one of the drugs we use for what? Leprosy. That's its claim to fame. So there's one weird thing we have to remember about Dapsone. Remember what it is? That you have to screen before you use it? Pardon? G6PD. Okay. So what happens if you give that drug to somebody who has a G6PD deficiency?
Hemolytic anemia?
Hemolytic anemia. You can see up there in that little cartoon, the red blood cells begin to pop. So people who don't have who have a G6PD deficiency cannot produce NADP. So what happens is those, and you put a drug on top of them that decreases their oxidative capacity, and the cells will lyse, and you can get a real severe anemia with it. So keep that oddity in mind. Let's see. Okay, so the same skin, those were just to remind us about skin. Infected blister, this is a bullous pemphigoid blister that has become infected, so teaching patients how to recognize that is important. Refractory disease, I'm not going to hold you accountable for the refractory. They're tough characters. But on the next page, top of page 5, it alludes to the following of those antibodies as a way to follow response to therapy. Also talks about discontinuing therapy can be attempted once a patient has been in remission for at least 2 months and decreasing. This is almost always going to be older people, so you can imagine that the morbidity and mortality risk here is very high. In fact, if you go down a little bit further on the handout, it talks about that the 1-year mortality is about up to as high as 50%. So it's important to have these folks in good care and also addressing other comorbid diseases. So if they have diabetes, that would be a big one. And they think that, they stated that higher comorbidities, higher mortality from bullous pemphigoid. So treating the whole patient is important. Probably their immune system and their ability to fight infection is what puts them at greatest risk for death with this disease. I put down the International Pemphigus and Pemphigoid Foundation. This was a great website. I learned a lot from it, so I thought it might be one if you come across or deal with these folks. This is a good one for both the caregivers and the patients. Well done. Okay. Comments about this disease? So hidradenitis suppurativa. Did Professor Bean talk to y'all? Did she do the Clin Med on this by chance? Pardon? Brooks. Okay. So this is another distressing disease. I saw quite a few of these in the diabetes clinic. So this is a picture, probably a more severe case. It's a disease of the follicle and the sebaceous gland. And they get a lot of destruction of those glands, and they develop these sinus tracts under the skin. And that allows for just a chronic setup of infection and drainage, and it's foul smelling at times, and it is a very hard disease to clear up. I mostly saw it in people who had diabetes, so that made it even doubly hard to get it cleared up. But Professor Bean and I shared a patient in family medicine who had a fairly severe case of this. She saw him for this, and I saw him for the diabetes, and it was hard. It was so cyclical. If his diabetes got worse, then this got worse. If we could ever get this better, his diabetes better, then his hidradenitis would get better. So really tough disease. Let's see. Very variable, that is true. Recurrent pustules, it's painful. It smells bad. The drainage is sometimes very profuse. The disfigurement, depending on where it occurs. Most of the ones I always saw were under the arm. I just think I probably never was going to see those that were in the groin area. But you can imagine how difficult it would be to deal with that. Depression, high risk of depression, so screening them, being aware of that. Feelings of shame, self-imposed isolation. You can imagine it might be hard to maintain more intimate relationships, all difficult. So treatment goals: prevent the formation of new lesions and really trying to prevent that progression that you see up there. Treating new lesions quickly and effectively to prevent those chronic sinuses that you see in stage 3. And eliminate existing nodules and sinus tracts to prevent scar formation. Did you all talk about the Hurley staging? Okay, that is an old staging approach. From what I read there, they feel like it's a very static staging process. So they are looking at quite a few new and validated staging. I didn't bring them because I think they're fairly new. This is an old terminology, probably one that most people would know. But be aware that there are new stagings coming along. So if you deal with patients in this area, you'll probably become familiar with those. Now they've got more forms that patients can fill out for you to try and assess the impact on, quality of life, depression screening, pain screenings are within those. So just to make you aware that those are out there. But I have stuck with the old one because most of the guidelines go along with these stagings. So stage 1 is mild disease. Most of the patients will fall into this category that I think you'll see. First line is topical Cleocin, so another antibiotic, pretty good at anaerobes. We use it for gram-negatives and anaerobes as well. Decreases the number of inflammatory lesions, so again, an odd kind of use of antibiotics for us, but anti-inflammatory and prophylactic against secondary infection. So it comes as you can get it as a roll-on. It kind of looks like a deodorant. Comes as a liquid, and you just roll it on. I don't know if it comes as a cream. I didn't check that. The one I'm most familiar with is the kind of the liquidy roll-on. Fairly well tolerated, doesn't cause a lot of skin reaction. The next one is topical resorcinol. I don't know how much this is used. It's mentioned quite a bit. We have talked about it when we talk about chemical peels. That is often one of the ingredients is resorcinol. I think that it is a phenol derivative. I could not find a pharmaceutical grade product, so I'm not quite sure how it's made. It may be compounded. I asked Professor Hughes if she ever used it, and she said no, it wasn't one that was as familiar to her. But I'm going to let you just kind of add it to your list of things that could be used. It's usually not used widespread like you would an antibiotic or a steroid. It's more for localized treatment. You can see there that it is used as a keratolytic and an anti-inflammatory. I would imagine that it is fairly, that it would cause a lot of pain on first initial treatment, I guess, inflammation. So it's clinical action. If you look under the third bullet, it reduces pain and promotes healing of lesions. So it gets rid of that old skin and brings on new skin. Let's see. It's also one of those that you taper and discontinue over time as the patient responds. My handout may be slightly different of yours. I ran it off first and then I made some amendments, and so I'm moving on to the top of the next page. Intralesional corticosteroids and systemic antibiotics. So intralesional corticosteroids can be used. They can accelerate healing, address inflammation, pain. They are done on a limited basis though. You'll see they're once a month for 1 to 3 doses. So they're not the mainstay of therapy like we've seen others. Systemic antibiotics can be used as well. And here the tetracyclines come back in with doxycycline or minocycline or clindamycin. What do you remember about oral clindamycin? What are the big side effects of it?
C. diff.
C. diff. So diarrhea in a lot of patients, C. diff is they develop in some patients. Good. Okay. Questions then about the mild stage, stage 1. Okay, let's move on to stage 2 then. So characterized by inflammatory nodules, sinus tract scarring, and that would be that picture in the middle there. Major treatment here are systemic antibiotics and hormonal therapy. So with hormonal therapy, we can use anti-androgens, or a combination of progestin estrogen products. So here, first-line antibiotics are the tetracyclines. Most patients can use them. If not, you can use erythromycin or cephalosporins. Erythromycin is a hard drug to use long-term. It's very hard on the GI tract. Most people can't tolerate it to a great extent. Lots of nausea, lots of vomiting. The clindamycin and rifampin are listed there also as agents. Rifampin, remember, can cause an orange discoloration to all secretions. Please warn that patients of that. Hopefully the pharmacist will too, so that patients aren't surprised by red tears, red pee, their poop turns color, so keep that one in mind. You see dapsone again, combinations of antibiotics, the rifampin, moxifloxacin, or metronidazole, going on after a lot of gram negatives and anaerobes. The oral retinoids have a limited use here. The only one that has been shown out of the retinoid to be of use is soriatane or acitretin. So again, anti-proliferative, immune modulator. The hormonal therapy comes more from just, is an older therapy, the anti-androgens. So they don't have a lot of data behind them, but they're still in use. You'll see the ones listed there that are most common. Cypoterone, spironolactone, finasteride. With females, you can also use a combination oral contraceptive as also. Keep in mind though, we wouldn't use the anti-androgens in pregnant women because you'll feminize the male fetus, and then we don't use finasteride in women. It's a contraindication as well. So you can see multi-prong attack. That is just at the disease. So they usually will have other complications. Did I skip that? I did. Go back to the top of, for me it's top of page 6. I don't know why I skipped that. Starts with general management. Do you see that? Did you all talk about these things? Smoking cessation, weight management, any of that? Okay. So So just as a reminder, so education and support, these folks need a lot of psychological support. So what is their family support, family acceptance, what is their depression screening would be important. Avoiding skin trauma, really important. If they are overweight and there's a lot of shear force on the area where they have the disease, then that increases their risk for increasing severity and spread of the disease. So going over behaviors that would help decrease that friction, like what they wear, clothing-wise, to decrease heat, friction, shear trauma. The dressings that they use, using petrolatum to keep it from sticking, using the avoiding adhesive tape, often that will tear skin. People also have allergies to those frequently. The elastic fishnet dressing, you know what that is? I should have brought a picture of that, shoot. You know the old fishnet stockings? Okay, that's what they look like. They're a cotton and they're elastic. So once you have a dressing in place, you can just slip that over that and it's not tight, it's not binding, but it will hold your dressing in place. So you can use it without adhesive dressing, adhesive tape to hold like a dressing in place or a 4x4 in place. If I think about it, I'll bring one in tomorrow. I like them. Smoking cessation, so there's a direct correlation with increased risk of this disease in people who smoke. And then you've just got the healing is impaired in smokers. Weight management, again, to help with just the skin, the friction, shearing forces. Chlorhexidine is a antiseptic, and so they recommend that they use that on not a regular basis, doesn't have to be every day, but it's a very good cleansing soap that can be used. Emollients with benzalkonium chloride, has antimicrobial properties that can be helpful as well. Help with that shear force depending on where necessarily they're, like it's under the breast, in the groin, helps decrease those shear forces. And then pain management, non-steroidals are the mainstay, opioids only if needed. So did y'all cover those? Sounds familiar, some are going yes and no. Okay, stage 3, I'm not going to test you on stage 3. Some things I want you to note on those, though, is that medical and surgical interventions are needed, usually to address the disease. Here's where the biologics show up. So again, I think is in your professional life, you will see much more application of these drugs to a wide variety of diseases that, as to this point, did not have that option. There's been some change in recommendations for these. Usually, Remicade was used primarily for this disease. Now the Humira or adalimumab has had much more data behind it. Seems to people do better. It's a little bit better tolerated. Remicade has some side effects that are more difficult, especially in an older population. So Humira is really the one that is preferred. But Stelara, which is a different biologic, it's an interleukin inhibitor, is also seeming to find a place in the treatment of this disease. The immunosuppressants can be used in acute situations where there's a lot of inflammation to kind of calm the disease down. Those are used. And systemic steroids the same way for acute. But not for long-term chronic control. Questions about those, comments? Anything I told you that was different from what you heard in ClinMed? Nope. Okay, let's take a break because LICE takes a little bit of time.